I want to thank you all for coming today. This has become an annual event, and that is the March and August participants of the Ghana Healthcare Immersion Program and their stories. And my name is Jennifer Morton, for those of you who don't know me, and I spend the bulk of my time in the Department of Nursing, teaching for that department. The Ghana Healthcare Immersion Program came to UNE about 6 years ago, and it's been a program that's been robust and growing. And it's really an exciting time for UNE because this is just one travel program amongst many, and there are so many opportunities for students, most notably the study abroad experiences, the growth of Spain, and the future of Morocco, among other countries, and also some of the other short-term immersion programs in social ecology and marine bio. And we are sort of the healthcare short-term immersion program. And so, again, really exciting time to be at UNE. So what we have today is a discussion about the program, what we do, what the goals are, and what we hope to achieve. And then I'm going to be turning it over to students. And I have a student, Emily Farnham, who's going to do some facilitation a little bit further into this talk. And so what we have over here to the right of me are our March and August participants, those that could come. Many of our participants graduated, and many of them are out on clinical rotation. So we have a good representation of a very interprofessional couple of groups that recently went. And so I want to ask the audience also, who in the audience, I know I've seen some faculty, but could faculty that have been on past experiences stand up? I know there's some out there. Okay. Okay. Yes, Dennis. Dr. Dennis, we see you. And are there any students prior to March and August that have been? Most of them have graduated. But, you know, I ask this because I think it also speaks to the growth and the commitment to the program. And I will say that a couple of these faculty members have been more than once. And we also have students who have been more than once. This sort of thing gets inside you, and it sticks with you, and it becomes something you want to do. So the purpose of this experience, and I have prioritized these objectives, okay? And they're prioritized for a really important reason, because the purpose of this experience is to provide students with an experience that serves to heighten their cultural awareness and sensitivity. And so while we provide primary care and related services, and those related services include community health education, it includes primary, secondary, and tertiary public health prevention strategies. We don't get that without having a culturally sensitive workforce first. And so that is our ultimate goal. It's not to go and do good work, but rather it's to go to learn to do good work. And then an emerging area of focus is some public health research activities. We have had some very good responses to proposals, both at an international level, but also local. We have one pilot research study going on there right now. And so we hope to grow that. We have an active collaboration with the University of Cape Coast and with the Ghana Health Service. So, where is Ghana? Well, it's in West Africa. And if you see by the globe there, it's over to the left. It's about the size of Oregon, okay? Population's about 9 million people. I'm gonna let, when Emily chimes in here, I'm gonna let her speak more to the actual cities where we're at. But the capital, Accra, you see the arrow that points to Sekondi and Takoradi, the twin cities where we spend our time. We actually fly into Accra, which is on the coast about a third of the way down. on the Gold Coast there. And so the rest of that time is a bus ride. So how are our objectives achieved? Okay, we do a fair amount of pre-departure planning, okay, and that includes cultural competence training, and you know, take that with a grain of salt, because what we understand about cultural competence is that it's never really achieved. It's just a cycle. So we start with training, and that training begins with self-awareness and humility. Our students are actively involved in fundraising. I was trying to run some numbers last week, and you know, over the 6 years, it's never been that important to me to track the number of pounds of supplies that we've brought, but it was somewhere around 1,500 total. Our academic and clinical goals, and understand that there are opportunities for students with respect to, we have, for the undergraduate and graduate students in WCHP, we have an elective available to them. For the Graduate School of Public Health, we have an elective available to those students. We have opportunities for students to collect clinical hours, providing that their program, their accreditation of their program supports what the supervision will be for those students. We've had students that have done independent studies, and we've also had students that have done projects or papers within a specific course in their discipline. We've also had students and faculty from every college participate in this. So it is a healthcare immersion course, but for students down in the College of Arts and Sciences, for example, if they're medical biology students and they feel like their path is going to be in their health professions, we will make we'll make it very possible for them to participate in this and have a very meaningful experience. And so academic and clinical goals are set, and then personal goals are set for students. There's a reason why students want to do this, and we want to understand what that is, and knowing what those personal and academic and clinical goals are helps us to shape the best possible program possible for them and for the program as a whole. The other thing I want to mention about pre-departure planning, is that we also want students to have an awareness of healthcare system in another culture. And you know, one thing that I want students to really understand is that we approached this program from a strengths-based philosophy, and that is, you know, understanding that in Ghana, compared to our healthcare workforce, they are functioning with a healthcare workforce of about 5% of ours. And although they're on target to meet several of their Millennium Development Goals for 2015, they won't meet all of them, but they've set benchmarks within their health service strategic plan that is getting them closer. And they're very proud of that, and we should be very proud of that too. When we talk about this program from an interprofessional vantage point, we have many, many health professions. We have 8 or 9 here at UNE. In Ghana, there is nursing, there's midwifery, there's medicine, there's physiotherapy, or as we call it, physical therapy, and there's social work. And to give you a perspective of the numbers, in Sekondi and Takoradi, which has a population of about 400,000 people, there are 6 physiotherapists and there's 1 social worker for those twin cities. So the healthcare workforce, 5% compared to ours, does a pretty amazing job, all things considered. And so what we go there with is this idea that people do the best they can with the resources they have. And I'll make one final comment, that they also don't get to spend money they don't have. The government doesn't get to spend money they don't have with the health system. So that's also unique. And so during achieving our objectives during, we work alongside members of the community and the health service, okay? So we're not going and functioning in our own Western silo of healthcare. We're practicing according to their evidence base, okay? We're using their guidelines. We're working with their nurses. We work with a physician that comes with us. And we also are working alongside community health workers, which is a really unique model of training a paraprofessional to deliver healthcare education. So there's active participation in clinical, cultural, and academic offerings, and Emily's going to speak more to that. So after and forever, and this is really important because the participants, both faculty and students, gain everlasting friendships. You know, we have social media that has really augmented the ability for these community health workers to stay in touch with students and faculty. And the cultural competency gains along the continuum for health professions practice, we know, and we're going to find a way to measure this, but we know this changes the way people practice. Responsibility for service, people come back to either do this or they set their eyes on something else, but there's a commitment that towards lifelong service. And what we know about UNE is our students come here with a commitment for that, and is evidenced by Tricia Mason's service learning program and busting at the seams. And then giving back to future participants. This is part of what I mean when we give back. Our students come and they present, they find ways to mentor other students, they serve as preceptors. I have a list of, I think, 7 alums that would like to precept students on future trips, and I just got an email the other day from another one. This is the list of both March and August of 2012. March has typically been kept to a smaller number by design. It tends to be a lot warmer during March. It's at the height of the dry season, and we typically have water issues, and we have to, by design, keep that experience a little bit smaller. August tends to be a much on the larger side, and for upcoming experiences in 13, we will be running an August experience, and that one will be quite large. We can probably accommodate around 25 participants, and to date, we haven't turned anyone away. These are interprofessional groups that range from anywhere from 6 to 8 health professions. And at this point, I want to thank you for your attention, and I'm going to turn this over to Emily Farnham, who is a student in our baccalaureate nursing program. Thanks.
Well, thank you guys. It's really nice to see such a big turnout. I know the volunteers all appreciate the support from UNE. So I'm just going to be talking a little bit about our experiences from a volunteer's perspective. So this is a picture of the girls' dorm on the bottom, and up above is our dining hall. So this was a general structure of the day, but it varied if we went to a church service or had a cultural immersion experience offered to us. We also kind of ran on Ghana maybe time. So whereas in America, this would be the strict schedule, it's more of an approximation of the time that things would happen. Oh, can you hear me? Can everyone? Okay. Oh, well, I don't quite know. Okay. So each morning there was a pretty dedicated group of people who would get up and run or walk. It was a great time of day because it was cooler, but it was also really nice. You got to see the sunrise, see the town, the village start to wake up, their morning routines, setting up shop, the vendors, getting ready for the day. And it also kind of offered a chance for us to have a presence in the community. They'd see our faces there and in the clinic. We were there such a short time, so that was a great opportunity. Our cook was phenomenal. She gave us a pretty typical American breakfast every morning, eggs, toast, all that. But then lunches and dinners, she'd alternate to traditional Ghanaian food and American food. Ghanaian food, we literally were right on the coast, so we had a lot of fish, peanut-based sauces, and lots of spices. But overall, very, very good. Our clinic opened at 8. Even though everything ran on Ghana Maybe time, people would be there before we even left on our run. So, 5 a.m., people are lining up there. It wouldn't be uncommon to see 20, 40 people already waiting there. As the week progressed and the word spread, more and more people would come. It was definitely an honor to see the community's respect for us and enthusiasm for seeking our care. So we used the primary care model. They would start with triage, and then based on their top 3 complaints that brought them in that day, they would be referred out to our services, PT, the lab, a lot of malaria testing and blood glucose testing, along with other ones. We had some community health education opportunities, breaking the patients into smaller groups to talk about the common ailments. We also had vision screening, so when we do a drive in spring semester for glasses, please pay attention to that, because we definitely used those glasses, especially reading glasses. And we also offered insurance to the patients that we cared for, which I really liked. It definitely helped us know that even after we left, they would be able to seek care at a greatly reduced cost, offering kind of a more sustainable model for us. So here's our clinic. It was also a church, so it's a nice big space. It was being remodeled right then, so we had a nice big space to work with. So they would come in, the patients would come in and be handed an intake card, which you'll learn about in a bit, and the community health workers, they were phenomenal. They would do the initial intake of height, weight, name, occupation, whether or not they had insurance, all of that. Then they'd wait and they would see triage, where we'd take their vital signs, general health history, and their top 3 complaints. And they'd go to the patient waiting area, where then the community health workers again would facilitate the flow of patients to the various providers. Our providers were 3 PA students who were supervised by the nurse practitioners. The PT department was 2 DPT students and 1 DPT faculty, physical therapy faculty. And it pretty much ran like clockwork, I'd say. Okay, so now we're gonna hear from 2 DPT students, Taryn and Nicole, about their research project they conducted while they were there.
Hello, everybody. I'm Taryn Wright. I'm a DPT student here at UNE, and I'm a 3rd year.
I'm Nicole Santarosa, same thing.
Okay. So for our program, we have an option of doing a case study or research, and we both knew that we wanted to do research, and with some scheming with our department and with Jen, we came up with the idea to do research in Ghana. So what our main project was to take their intake card, which was severely dated. I don't think it had been changed since they started doing this program, I think 14 years ago, so definitely needed a reworking. Through the modification of this card, we hoped to streamline their demographic information, do a little bit of work with their malaria section. Their prescribing procedures and testing procedures were outdated and they needed to be redone. Through our redesign card, we've been able to code the data and put it into a database, which we're working on now. And since we are PT students, we wanted to make it a little bit more PT friendly, which had started in prior years as physical therapy is becoming more important to that community there.
So this is the old card, and it's kind of split. This is the top where pretty much the name, the patient demographics can be filled out by a community worker, and then they'd come to triage, and nursing or undergrads, whoever was there, would fill that part out and fill out their major complaints, but it was kind of really haphazard. This is the bottom part where once they went to the physician or the provider, they would receive their diagnoses. And then this was what PT designed for our own documentation purposes. So there were two separate pieces, and it just made everything very, very confusing. So this was the new card. You want to remind?
Sure. So we kept some of the old stuff and integrated some new things. The demographics remained the same, and the patient complaints and the diagnoses are all on the front piece, or the front side of like a printer-sized piece of paper. On the back, we had intended that to be used a little bit more for the physical therapy aspect of it, and taking our history, doing our tests and measures and things like that. As we continued through our week-long experience in Ghana, we found that this new card actually isn't all that great, so now we're working on another new card that will hopefully be ready to go in August, or in March, and then again in August.
So kind of more of what Taryn already said is the coding part. We really want to be able to code the complaints and the diagnoses and form a database so we can keep track of these patients, because they are very dedicated to our service there. If you tell them to come back in 6 months, they will come back in 6 months. And even today, we had a Ghanaian patient call Larry, and we were able to look it up in our database and figure out who it was. So it's the beginnings of kind of a more longitudinal studies that can be done.
While we were there, another part of our plan was to educate all of the healthcare personnel that were in attendance on how this new card was going to work and what PT can do, what we can't do, so we could we hoped to streamline the referral process and perhaps increase the amount of patients that needed to be seen by PT to actually get there.
This is more intervention stuff. Don't need to worry about it. And this is kind of, after we draft everything, we're going to run some just demographics on patients and look at specifically what PT patients we saw and what we were able to do from our perspective, and make a big poster presentation for Research Day. That was kind of our deal, and yeah.
All right, so as Dr. Morton said, we stayed in Sekondi. It's a fishing village at the very southern, almost as southern as you can get in Ghana. So that was the fish statue that was our landmark. So if you managed to get lost in the tiny little village, then you could at least find your way back. And I guess the color's not that great, but directly back to the right was our dorms with that teal roof. We could actually, if it got quiet enough, we could hear the ocean at night, so we were really right there. And their main source of income was fishing, and these are examples of the boats that they used for that. Is a very busy fish market nearby. So we opened up a new clinic in Mpinsen, which is a nearby town. It was a one-day clinic that we opened. It's our second time there. We were there in the previous March trip. And it was really encouraging for us to see such a great turnout for that day, despite the fact that we hadn't necessarily been so well established in the past. We had to modify our clinic a little bit because it was in the chief's house, the village chief's house. And so triage and lab were a very busy room, not huge. The providers were also in a modified area, but things seemed to move pretty smoothly. The intake, waiting area, pharmacy, and physical therapy area were all in the courtyard. It was a very memorable day for all of us, and there was quite a variety of diseases that we got to learn quite a bit about. So our cultural immersion experiences were great. We had some awesome variety. We toured a castle from the 1400s. It had a rich history of slave trade. We went to a church service, the same church that we ran the clinic in. Lots and lots of music and dancing. It was a very long service, so we got a lot of energy. The Ghanaian drum group came. They performed with their dancers. They taught us drumming technique and performed for us. We went on a rainforest canopy tour. We had pickup soccer games within the community, and we got to visit some of the local markets to get gifts, souvenirs, fabric, all of that. Our academic immersion was consistent throughout, but some of the noteworthy things, aside from the interprofessional work while we were in the clinic learning from each other, we had 3 guest speakers. A nutritionist came. She talked with us mostly about Ghanaian dishes and healthy alternatives, especially when weaning a baby from breastfeeding. It was really interesting to learn all of that early on in the week because it offered us a chance to have that information when we were teaching our patients later on in the week. We also had an anthropologist come. He talked about sort of the social issues in Ghana, gave us a good idea of their culture, and then we had a physician come to talk about endemic diseases, which he came a little later in the week, so we had a lot of questions for him about what we had seen. We were able to tour a regional hospital and kind of compare and contrast that to American hospital, and there was also an exchange at a local high school and a tour of that as well. And so now we're going to pass the mic around to our volunteers who are here today. I don't know, are we using that one? Okay, cool. And they'll share their experiences.
Hi guys. Oh, is this on?
So, this is for Taryn and Nicole first.
Yeah. It's on. Can everyone hear me? Oh, okay. I'm Ellie. I was part of the August trip, and I'm going to talk about the nurses in the group were able, towards the end of the week of our trip, were able to go experience, and you can see from that picture up there, the Shama Health Center, which is a local kind of rural maternity clinic. We were able to observe how the nurses there did their prenatal, interpartum, and postpartum assessments on various different women in various different stages of their pregnancy or after their pregnancy, postpartum, so forth. We were able to help on the assessments of one lady in particular, which really stuck out in all of our minds. She was in labor. She had a blood pressure really, really high, around 200 over 110 or so. And it was very interesting to see how these nurses over in Ghana just dealt with such a potentially serious complication, and how they handled and cared for these patients. You can see on the picture on the top left, those were the 2 head nurses, and they're standing in like the one room that was like the maternity ward where all these patients were. On the top right, that was their supplies that were in the same room as, you can see on the bottom left, that was like the delivery room. And you can really see like how different it is from what we're used to over here in America. And it was very interesting kind of us nurses going through the supplies and seeing what they had on hand versus how they dealt with patients who did have serious complications like this woman with very high blood pressure. And then of course, at the bottom, that's me holding one of the newborns, and that was just an added benefit, getting to be able to hold the newborns, and we actually were able to observe the head nurse wash the babies and kind of assess them, and then as well as assess the mothers who were still pregnant, listening to the fetal heartbeat, which is very, very different than what we do here. So overall, it was just a really great experience and a really great viewpoint of how a different culture handles pregnancy and all that. Okay.
I'm Nicole again from physical therapy. Welcome. So we had kind of 2 standout patients when we were there. There was, on the top left was kind of our usual, here's a cane, like very, very primitive physical therapy. But then we had a spinal cord patient come in on the left, and he was our like not stereotypical, I don't know, gold star interprofessionalism at its finest. He started telling us his story, how he was in a car accident, he was a spinal cord patient, he was not really moving around, and his story was getting weird. So we pretty much called in everybody. We got social work to come talk to him. We were working with him on transfers. Nursing was working with him. Wound care was working with him because he had some pressure ulcers. And by the end of the week, he was very, very interesting and had a really cool story. And social work was really, really helpful in getting to know the mentality. He had this mentality that he was in a wheelchair and couldn't do anything. He was a grad student or college student before. And so it was kind of us understanding in their culture, being in that position, they feel like they're useless and can't do anything. And we were like, what? No, you're awesome. You can do a lot of things. You still have a brain. So that was kind of part of, it was really cool to see everything, how you could, like, in this little church, just grab a social worker and get everyone to work together for the one patient. And he's the guy that actually called Larry today.
One other standout patient that we had is the other picture of Nicole and the gentleman with the very large hump on his back. So he had originally came in, I think, for a wound to get checked out, and we saw him and decided that we wanted to see him too. So after our exam, it was actually really interesting for us because we had just finished our adult neuro class, so we had spent the entire semester previous to this learning about testing in neuro patients and positive signs of upper motor neuron lesions and just like spinal cord injuries and anything you'd want to learn about it. So this was pretty fresh in our minds, and we were able to do some reflex testing on this gentleman, and he was extremely hyperreflexive. It was really neat to see like a positive test for clonus. We checked him at his ankles, and it just beat until there was no tomorrow. And I mean, just like seeing someone who is a functioning member of this community in a third world country that has such an obvious deformity and how they can make these things work in their daily lives is a really inspiring thing to see. So that was another patient that stuck out in our minds.
I'm Caroline. I'm a nursing student. I had the opportunity with Emily to work with Jen Morton, Dr. Jen Morton, on her research project involving a pregnancy register. What we were finding was that despite the WHO interventions in Ghana, there was no decline in the infant mortality rate in over 15 years, which is kind of scary that they're doing all these interventions and nothing's changing. So she implemented this pregnancy register, which was essentially a perinatal medical record, which had things on it which you would expect, like vital signs and immunizations, but it also had things like mosquito nets use and also where they get their clean water from. And they did already have an antenatal card, but it was really not very specific, and it didn't include things like, you know, your vital signs. Like you wouldn't be able to see a trend of how their blood pressure was to determine if preeclampsia was happening. And so the pregnancy register really helped streamline the care, helped the community health nurses communicate with the midwives who were actually, you know, involved with the delivery of the babies. And then, let's see, and it just helped overall with the congruence of care. So by implementing the pregnancy register, there's a better continuity of care, and then we ended up speaking with all the community health nurses and the midwives and how they liked using the pregnancy register, and they said that it was really helpful, that they didn't have to try to remember their patients, that they didn't have to, they could see where someone left off and continue their care with them, and then also that they would know their medications and make sure that the pregnant women were attending their antenatal visits. So it was really neat to see that. One problem was that they had to carry the books with them, because the antenatal card, the pregnant women were the ones holding, or they were the ones that kept it. And so the difference was now with the pregnancy register, the community health nurses were keeping them on record instead of just the women. So if something happened to the pregnant women, the card would be lost. So it was really helpful in that way, but it was interesting to hear their stories about how they try to go find the pregnant women. They'd have to go on canoes to go do their antenatal visits. It seemed very difficult. So we were trying to make it easier on them with this pregnancy register, and and they all thought that it was helpful. So if you guys are really serious about going to Ghana, kind of have a focus so that you can help them help them with, what am I trying to say? Yeah, just help them improve patient outcomes, because we all have our different ways of doing things, but just so if we can help them with a better way of doing it, then it'll improve outcomes, which is good.
So just like Taryn and Nicole were talking about those standout patients that you have that require that whole interprofessional collaboration, this would be the patient that I had. She was a 3-year-old, came in, her mother was telling me that she had a cough and maybe fever. She thought it might be malaria and wanted treatment for that. Her vitals were okay. I hadn't done my pediatric semester yet, so I didn't really know what would be tachycardic for a 3-year-old, but it didn't quite seem right. She didn't have a fever, but she seemed so lethargic, so I knew something wasn't quite right. I'm used to 3-year-olds bouncing off the walls, and this one, she just sat in her mom's lap, just looked so sleepy and not well. So when I was assessing her, I noticed her fingers and her toes, just like in my pathophysiology class, and I never thought I'd actually see it in a clinical setting. She had clubbing. As you can see, that's a sign of long-term oxygen deprivation. So as you can see, her hands, her fingers are really wide. The fingernail beds are really, really wide. Her fingernail beds were also cyanotic. You could kind of see it in her gums as well. She was clearly just not a very healthy little buddy. So called over the PA students and the nurse practitioners. Her O2 sats were in the 70s. Obviously, that's pretty alarming. I walked her around the clinic, and when we sat her back down, they were in the 60s. So this little buddy clearly needed some help. The mother, seeing my reaction to things and seeing how many people were working on her daughter, she really fearfully admitted that she didn't ever return, like the midwife had suggested, for her child's 1-month checkup because of a lack of insurance. That was quite heartbreaking for us. So we could rule out cystic fibrosis given some reports by the mother, and we believe it was likely a congenital heart defect. And it kind of had a great outcome, actually. So this was on a Wednesday that she first came in. She returned the next day, Thursday, for further eval by the PA students. You can see on the bottom right picture there with her. And then by Friday, she was on her way to Accra, the nearest major city, to be further evaluated. And through the collaboration with the Ghana Health Services, she was able to afford advanced health care. So that was that standout patient for me. And here's to Cheryl.
I'm Cheryl, I'm a PA student. Just to add to the patient that Emily was just talking about a little bit, the thing that we think she had was tetralogy fellow, which usually in this country would be caught prenatally and fixed as soon as possible. And so that, catching, if it was that, in that patient at the age of 3 for us was concerning because we don't know if her outcome is as good at that age, but also very rewarding because without that being fixed, without some intervention, her life expectancy would not be past, I don't think, 20 at the most. And she was a pretty happy little girl for not having too much oxygen. And I don't know, it was just, that was a huge patient for us, I think, for everyone, those couple days. But they asked me to talk about this patient who was one of the wound guys that I saw. This summer, one of my clinical rotations was at the Mercy Wound Healing Center, so I got to do almost all the wounds that came in. And this particular guy came in with, it was probably, I don't know, 6 to 8 centimeter at least diameter, circular, probably mixed venous and arterial disease wound on his ankle. And it had been going on for up to a year?
He was seen in March.
Yeah, it was months. And he came in with it just wrapped in like a dry, not particularly clean gauze. But, you know, it was pretty stable in a way, but it was covered with, it was kind of crusted over and stalled. It wasn't going anywhere, and he was looking for help. So we saw him every day that week, and using disposable scalpels and very conservative, gentle debridement. He improved over several days, and hopefully we jump-started his healing because, of course, we were going to leave and couldn't see him all the way through to completion, but hopefully just bringing some blood and cytokines and, sorry, I'm going to get too technical. Hopefully that jump-started his healing. Yeah, and it was also great because it was another example of how those guys in Ghana, they really come back. I asked him the first day if he could come back the second day, and you know, he was waiting there at 4 a.m. or something when I came out. So we had a lot of people like that, but he was kind of special.
Hi, my name is Kristen, and I am in the Master of Public Health program online with UNE, and I'm a health teacher at high school in Rumford, Maine. So this is only the second time I've been on the UNE campus, and I've been in school here for 2 years. So anyway, Jen mentioned in her introduction about how there are many different health disciplines that go on the trip, and how she is really able to almost tailor the trip, you know, to your interests. And this was huge for me. I got to visit a high school in the area. It was all girls, and that happened within the past definitely 7 years. There's a real push in Ghana for female education, and out of all each region in Ghana is required to have at least 3 just all-girl schools. And so this one used to be both genders, and now it's all female. So it was huge. There were about 1,400 students, which is way bigger than my school, and it was all girls. So it was really eye-opening for me. You could board there or be a day student, and it did cost money to go there. The picture in the middle shows one of the dorm rooms, which I was just shocked by. 32 girls slept in one room, and it wasn't a big room. You can tell. I mean, there's 8 beds. If you go in on the right, 8 beds on the bottom, 8 stacked on top, and there's about a 3.5 maybe foot wide path in the middle, and then 8 and 8 again on the other side. So, and all their bags were just stuffed up on top of these, like, I don't know. It was just crazy. I don't even know how they live that way. But we got to talk with, well, the bottom right picture, a classroom full of girls. It was actually their last day of school, so we were really lucky to get there when we did, when there were students there. So we got to talk with them, and we asked them how they like their living conditions. We like it. Like, okay. So they have, you know, a lot of the same classes that we do here. We get to see some classrooms, biology, chemistry, physics. So they do, you know, a lot of the same stuff that we do here. class-wise, but there's definitely a much bigger focus on home economics. That's kind of dying here in the US, but there, it's a very big part of their culture. And so there was a huge room for the home ec for, cooking and sewing. A lot of people make their own clothes and they need to know how to do that, and they can make a living by doing that. So that was interesting. And they actually had it was like a bedroom and a bathroom that you learned to clean. Like you learned to make a bed and you learned to wash walls and clean a bathroom and everything. So that was interesting. The dining hall the kitchen was another really eye-opening, just crazy thing for me. We went into the kitchen and they literally had, it was like a cauldron full, they were cooking corn, and there were like trees. They had lit, it was wood fired, literally. It was a tree, and it was just it was taking up the whole room, but it was lit underneath the cauldron, and it was cooking. I wish there was a picture of that for you to see, but yeah, it was just crazy. I showed it to the lunch ladies at my school, and they were like, we will never complain about, what we have here. And speaking of that, I would love to send some of my students there, because they just complain about everything here, and I'm like, you have no idea, how good you have it. So that was really cool for me, and a really good example of how Jen really makes an effort to get you places where your interests lay. So that was really cool.
This is me. So we also went to a national park and went on a canopy tour in the rainforest. We were about 150 feet up from the ground. You walk on these bridges, as you can see, and it's just a bunch of wood planks, and then on the side, it's like two pieces of metal, very unstable, and then you have this rope netting to keep you in. So you're only allowed four or five people, or six. Or 10, whatever. You're only allowed a few people on the thing at a time, because if you do get too many, each person's step rattles the walkway, and, some people get kind of scared. But yeah, it was one of the highlights. It was cool to see the natural habitats, if you will, and, be a tourist for a little bit. Barry, you want to talk about fabric?
So a couple of the other cultural immersion activities we got to do, in the top picture on the left, and then the one next to it, those were taken in the market in Takoradi. We went there for an afternoon, and we were able to do some fabric shopping. And then there is this wonderful seamstress named Magdalena who will come in and make anything that you want. And a good chunk of us today actually are wearing things that they had made for them. I'm sure they'll be happy to model them for you later. Larry, who was our DPT advisor person, seemed to have a really great eye for picking out fabric, and I think he might have actually bought the most out of everyone there. And I mean that in a nice way, because you did a great job. What else? I think that pretty much sums up those pictures. Oh, that's a good picture.
Cool. So just to wrap things up, Madasi means thank you in Asante. And so we wanted, in Shanti, and we wanted to first thank all the communities. They welcomed us with open arms, allowed us the opportunity to practice our future professions in a way that we normally would never be able to. They were very compassionate, very, very welcoming, and truly we'll always remember that. Also, a special thanks to, so on the left is the reverend of the church that we not only stayed in, ate in, slept in, all that, but also the church where the clinic was. Our community health educators, which are on the right, they were, like I said earlier, phenomenal. They were completely instrumental in the entire running of the clinic. They were there for us for our cultural hurdles that we needed to, just describing symptoms of a disease in a culturally appropriate way. Also figuring out ways for patient teaching and lifestyle modifications that are even conducive to their lifestyles. They were there for that. Many of them, they're in their early to mid 20s. They might be interested in future healthcare professions, but they were phenomenal human beings. Ghana, the nurses that we got to shadow were also very, as Caroline talked about, they'd have to go on canoes to go do prenatal assessments. I mean, they were so dedicated to their work. It's definitely something that I will always take with me in my work. And then also on the state side of things, thank you to Tricia Mason. She was pretty much the glue that held us all together in terms of all the paperwork, the visas, the immunizations, the donations, everything that she did before we even left Boston Logan. That absolutely made the trip possible. Wouldn't have happened without her, so thank you so much. Thank you to the dean, and also thank you to the professionals. We had Larry and Kathy are here today, as well as the faculty members of UNE. Really, it was an amazing opportunity to learn from them, from practicing professionals, to learn your future profession in a clinical setting. And of course, we wanted to thank Dr. Jen Morton. She put this whole thing together and offered quite the once-in-a-lifetime opportunity. So now we'd like to open it up to, oh wait, just kidding. So if you're interested in getting involved, we have the website up. The next trip will be August 20th, no, just kidding, July 26th through August 4th. And if you have any interest, please, approach one of us or take a look at the website. And we hope to see anybody interested come. So now we'd like to open it up to any questions that you guys may have for us.
If you have a question, just raise your hand, wave it around, and I'll come over with a mic. Or I'll pick someone.
Yes. Well, one of the nursing students with me had this question, but she wasn't able to come. For her mother's purposes. Did you ever feel unsafe there at all?
No, where we slept was locked at night. But even then, it was what? There was a guard. Oh yeah, and there was a guard there as well. But also that society was so welcoming to us. I don't think anybody would lay a finger. They were so welcoming and grateful for our presence there. That wasn't the type of society where you would feel I'm speaking for myself, but I think I speak for all of us. Yeah, it was a very safe experience.
I have something to add to that as well. Not only were the sleeping quarters and the clinic and where we were was really safe, but wherever we went, whether it be the marketplace or the fishing village or to get fabric, wherever we went, we were always in a group. No one ever went alone, as well as they always had at least 2 or 3 community workers who lived in Ghana come with us. So they can help us communicate with the villagers, communicate with them, and if we ever needed help talking to them or whatnot. So we were never alone. And I know personally I never once felt unsafe, and I think that's probably the consensus about the group.
Yeah, they almost made us too safe. Like if your foot was off the sidewalk, someone was like putting it back on there for you. And one time I left my camera. We were at the last day at a resort. I left my stuff and walked 10 feet away, and 2 of our community workers were guarding my stuff. And I was like, it's fine. It doesn't. They take it so seriously, almost too seriously.
Yeah, I was wondering if any of you ran into a situation where there was a conflict between beliefs around folk medicine relative to your allopathic approaches.
That's a great question. One thing that we make a point of every experience is having a local cultural medical anthropologist from the University of Cape Coast come talk to the students. His name is Kobina Isia Donka. He's a very prominent cultural anthropologist in Ghana, and he really makes a point to teach the students to really understand the traditional practices from the vantage point of embracing their perceptions of health as being something that they own, and to try and take ours out of the equation because of the different culture. So I think that as far as specific traditional practices and a clash of culture, folks that practice that solely probably wouldn't come to the clinic as a patient. In my time, I've been doing this for 14 years, I haven't seen a conflict to the degree that it created any problems. We were always able to reach common ground. And one thing, you know, having a nutritionist come and having a cultural anthropologist come, you know, helps students to be able to understand some of the traditional practices, some of the herbs, some of the spiritual practices that augment the healing process. So.
We went to the PT hospital, and it wasn't a conflict that we had, but the head PT there, we were trying to understand her education, and she was saying she had to take a couple years off. And what happened was she had Bell's palsy, and since she had the paralysis, her family forced her to quit school and stay at home. Because that's what the traditional medicine said. They took her to the tribal leader, and this is what they told her to do. So she was, and now she's a PT, and she's like, if I would have known, I could have gone to rehab, and I wouldn't have had to do these things. And so she was a really good insight into, at first, she told us that usually you go to your tribal leader, and then when that doesn't work, you seek out other medicine. It was kind of interesting to see that like you can see they're in conflict as well with what they think would be the best avenue.
We have a question back here.
I was just wondering what the out-of-pocket cost would be for students who want to go?
The out-of-pocket cost for a person that seeks health services in the...
For a volunteer.
For the students.
Oh, I'm sorry. So for a student cost or a participant cost, I think that we can roughly say it's around $3,000, and you know, it sort of fluctuates by $200 or $300 in either direction, but that covers the flight, the room and board, all the ground transportation, and the cultural immersion entry fees. Yeah, and if you are a student at UNE, there is an endowed scholarship through the CAM Scholarship for Health Profession Students, and there is also scholarship money through the International Education Office, and that office is on the Biddeford campus. So there is scholarship money available, but the cost that I quoted really covers everything.
What are some of the ways you guys, or some of the experiences that you guys have used, and how have those experiences affected your functioning as a professional now that you're back in the United States, and how has it affected you personally and professionally, really?
So the question was how...
Enhanced? Yeah, okay.
Okay.
I guess it's, for me, it's been more just of a realization of how much more sophisticated we are here, and then to see how simply they're able to take care of problems, and then be able to take that simplistic approach and apply it here. I mean, it's probably common in Ghana for somebody to see a doctor maybe 2 or 3 times in their entire life. You know, here we're seeing doctors 2 or 3 times a year. So I think for me, it's kind of I've been able to kind of take that approach. So there's a lot of stuff that we can solve on our own. You don't need to be running, constantly to healthcare providers. In just through education, and we can kind of maybe take care of a lot of this stuff, without involving the system. I mean, one of the big problems in this country right now is just the cost of healthcare, and I think one of the reasons why it is so expensive is that it's so available. And you take a country like Ghana, and it's not as readily available, and obviously the costs are a lot less. You can argue that the quality care certainly is different, but from what I saw, people were pretty healthy there. I mean, the general population is pretty healthy. So I think there's something to be learned there and apply it to our system here.
I think for me, I recently graduated with my RN license. I'm now back in the bachelor program. But for me, being such a new nurse and going to an experience such as Ghana really strengthened my clinical skills. Not only did it, you do your assessments, you do your vitals and whatnot, your health teaching, but to do that with another culture and have to tailor it to how they learn and how they communicate with you was something that at first was very challenging for me. I can remember an experience I had towards the end of our week there. We had an older lady come to the clinic, known diabetic, but their diabetes is very hard for them to manage, so her blood sugars had not been managed properly. She came to the clinic with obvious wounds on her feet, and I remember her 2 last toes were completely gone. They were just down to the bone. She had an ulcer on the bottom of her foot that looked, when you first look, it was like it was small, but then as one of our PA students started debriding the wound and kind of further assessing it, it tunneled throughout her foot. It was a pretty serious situation, and she thought that we could just, and in essence, cure her. Just dress it, put some medication on it. But in reality, she was going to lose her foot. So it was a pretty extensive family history of diabetes. The daughter had it. I believe the aunt had diabetes. So in terms of health teaching for us nurses, it was very challenging to overcome. They've been to the hospital for this, but they didn't quite understand what it meant to control their blood sugars. They didn't understand what it meant to have a high blood sugar and how it affects your vascular system and how it can cause all these problems and vision problems. So for me as a nurse, this whole entire experience really strengthened not only my health education, teaching, but just my clinical skills overall. I don't know if anyone wants to add.
I just want to give a shout out to the nurses on the trip because I was surprised over and over by how much they were focused on patient education, and I haven't, it seems like, I guess, in the world that you run out of time to do that, and sometimes I haven't seen that as much out working, but these guys are really dedicated to it and they're really good at it, and I had so many patients come to me telling me already what the nurse had just taught them, and the patients were enthused about what they had just learned because they don't learn that somehow over there sometimes. And so that was just a really key thing about interprofessionalism that I have definitely kept and that I want to utilize with the nurses that I work with someday. I want to utilize that skill and that passion that they actually have. You guys did great with that.
Hi, I'm in the nurse anesthetist program, and I was just wondering, where would you guys be able to use me or the fellow students in my program, and are you guys going to be planning to start any kind of surgical cases in the next couple years at all?
That's a great question. We've actually had some discussion with your current director to troubleshoot where nurse anesthesia could fit into this. And this program was developed and has been refined based on the ability to work alongside the Ghana Health Service and provide primary care and related services. Having said that, and speaking with Professor Massey, we could fine-tune some some outreach in the area of pain management, pain assessment and management, and provide some experiences at the local hospital to augment the OR experience. But it probably will never be shifted to an acute care experience. It will always be outreach, but education, pain management and assessment, and I can tell you that in our physical therapy, I always want to call you physiotherapists. Our physical therapy colleagues will tell you this is a very laborious culture with a lot of aches and pains, and we know that nurse anesthesia has wonderful skills in assessment and management that could be translated to another culture with teaching. So I think if there are nurse anesthesia students that are interested, it would be beneficial for us to get together with some of your faculty and discuss roles. But we have had this discussion. Thank you for the question.
This is directed more towards the DPT students who decided to do some research over there. And I was just wondering if you guys had a specific research question that you were trying to answer, or some sort of hypothesis, or if you were just kind of like, let's revamp this and see what comes out of it.
Well, the honest answer would be no. We were meeting for our clinicals, and we knew we wanted to do research, and we knew we wanted to do Ghana. And if we went to Ghana, we would have to move our clinical. And then that's usually when you start planning your research project. And our one professor, Sally McCormick, was like, well, why don't you try to do both? And we were like, okay. And that's kind of where it started. And we met with Dennis, and then we met with Jen, and kind of came up with an idea that things need to be changed, more of a program evaluation. And PT is going now. We do have a presence, so it would be nice to have a presence on the card and stuff.
And what they did, their project, and I would call it a project. It wasn't research in a sense that the aim wasn't to create generalizable knowledge. It really was a program evaluation project. And if there is a question embedded in that, it's really will a refined clinic card streamline interprofessional documentation practices? So there weren't human subjects involved, but rather it was really a pilot of a new documentation system. And I want to really give them a lot more credit than they gave themselves. They said that their new card wasn't a good one. It actually was a really good one. They had some pretty harsh critics with all of us, and we made them switch gears. They were so patient with us, but there were constant refinements being made, so it's really hard to evaluate, and they were very patient. And the end result is they had a really good clinic card. It's just being refined to a better one. And so, yes.
I found with this trip, as a seasoned nurse practitioner, I work in an isolated environment, but with the physical therapy students, that's the one thing that can be left behind. They can teach patients their exercises, whatever they need to make them feel better, and not really have to worry about a pill or going someplace. What they taught was culturally appropriate, could be done in the home. So a lot of anecdotal research went on. I don't think I've ever used PT as much, but they were there, they were excellent. And what I found also was they told you what they were doing. The physical therapist told the providers what they were doing, why they were doing it, and what they hoped the outcome would be. So anecdotally, they did a great job.
Are there any more specific dates that we should know about, like when we can sign up and for education time? Are there any dates we should write down?
April 1st will be the deadline for the summer experience, but you know, I would encourage, if people are very serious about it, I would encourage to get applications in at any time. And everything can be found on the website that's up, as well as the scholarship information. Okay? And then we'll follow up with folks with respect to immunizations and visas and so forth. And one thing, somebody asked about expenses. One thing I didn't include in that, and it's hard to know depending on what you have for insurance, but some insurance companies will cover the shots and some won't. But if it's out of pocket, I'd say it's around $200. And of course, the passport and a visa for single entry is $60.
Anybody else? Questions?
I was just going to say, Jen had been after me to go for a number of years, and for various reasons, one big one being my dissertation, I wasn't able to go. So this year in the spring, she approached me and she said, "Your dissertation's done. You have no children getting married. You have no excuses left." And I'm just so glad that I went. It was an amazing trip, and I think I'm the only one here from March. But, you know, we did have challenges with water, but, you know, it was an amazing interprofessional opportunity. The students would just come to the clinic and say, you know, I'd like to spend the day with the pharmacist today, or I'd like to spend today in the lab learning how to do the tests, or gee, I'm a med bio student, but I'd really like to learn how to triage. And so I found as faculty, that's sort of where my role was just helping the students that maybe didn't have some of the skills still be able to be very effective in the clinic. And it was just very, very worthwhile.
Questions? Comments? Thank you so much, all of you. That was great.